Hi, this is Junaid, AINeuroCare stroke and epilepsy specialist. Today we're going to continue with our advanced practice providers and how it impacts your choice of medical specialty. Look, there are important questions to be answered as far as what about physician extenders, whether it be nurse practitioners or physician assistants, where do they lie, and how does it impact you and your future choice of medical specialty. The first and the foremost question is that how does it impact physicians and their salary and job considerations and prospects, training, autonomy, and esteem. And then, of course, there is impact on care itself, the cost of care, NP training, is it adequate or not, and all those kind of questions that we have to answer as far as healthcare in general, so you guys understand. But more importantly, you need to sort of figure that out before you make your final choice of medical specialty as well. Look, the first and the foremost is that, yes, clearly that has an impact on salaries and job prospects. I mean, this is just one heading. Wisconsin Hospital replaces all anesthesiologists with CRNAs. I mean, they do come significantly cheaper. And then this is another example, 15 docs fired from Illinois health system to be replaced by nurse practitioners. We're seeing a lot of these things happening as far as that is concerned. Your job prospects are getting slimmer and slimmer as far as this is concerned, and this directly impacts your reimbursement rate, given that we're going to come to the cost of care itself, but definitely it is impacting physicians' job and salary prospects in the future, no questions asked. What about autonomy and all those things? As far as like this is a blog post openly written as far on Facebook is concerned, is a physician community in which they say that they are actually replacing physicians by nurse practitioners, and more importantly, they have to now compete with nurse practitioners on getting procedures done as well, especially in training as well. And there are significantly fellows who are graduating after working for years and years, and then to come in and see the nurse practitioners within 2 years getting the same access to providing care to other patients. This becomes a little bit challenging, and this can be technically considered a problem as well. However, that's why there's a sort of a movement within the providers itself that we have to make sure that we are differentiating between the word physician and provider. Interestingly, in the United States, it's not general practitioner, right? So GPs is where Europe and European countries come in. Even in Pakistan, we use the word GPs, general practitioners, which denotes over here as primary care providers, which incorporates family medicine and internal medicine. This over here, there's a growing movement that we should differentiate between the word provider and physician. And one of the reasons that they think it is important that sometimes we feel as physicians, and not me personally, but at the end of the day, there are physicians who are opposed to it, that this is not the right way or the right approach to actually do this. Either way, these are things that are important in terms of your consideration. Corollary of why the term provider gates our job is not to shovel healthcare. We provide our patients expertise, advice, and care. They're really important questions, because the word provider causes what we call false equivalency. False equivalency means that physician versus nurse practitioner would become both providers, and therefore any provider can take care of you equally is actually definitely a false equivalence. There's no question about it. However, is it just semantics or is it real consequences? You can decide on that on your own. As far as choosing your medical specialty, definitely take into that consideration. It does impact clearly, right? There's depersonalization, deprofessionalization going on. We have seen anesthesiologists definitely most impacted because of the CRNAs. We are seeing the same thing going over in the neuro ICUs, because to be honest with you, I can't function within the neuro ICU without the help of nurse practitioners, because there's just lack of neuro intensive, and then you have to do too many things, and therefore nurse practitioners, in my opinion, are essential. And I don't care you call the word provider, practitioner, it just doesn't matter to me, because we have to take care of the patient. But there are specialties as far as family medicine, internal medicine is concerned, when a mom and pop shop, a nurse practitioner can open up and then compete with a fully legitimate licensed physician at the same level, even though the nurses, insurance companies are reimbursing at a rate of 85% to 100% for physician. I think that's not enough, especially with the growing demand and the growing expense of maintaining and doing practice management. And there's a growing consolidation going on, which we talked about previously in terms of the overall healthcare picture as it's moving towards. So clearly it does have real consequences. And essentially, I think it degrades both. And I think that I agree with this particular statement that nurse practitioners are individual and entity, and they are sometimes in certain situations are better than physicians, period. And I'm going to be honest with you. chronic care, standardized care approaches that I've talked about in my previous lecture as well. For example, stroke, when they are do sometimes a really better job than I do personally, because they have this compassion that comes from a nursing sort of background. For me, I'm more analytical and making sure that all the scientific basis and clinical studies and everything. But care is not just about that. Care is about holding the right hand at the right moment, actually have the time to do it, and also make sure that the patients do feel supported, educated, and this definitely improves, in my opinion, patient compliance with the medications and improves engagement. So definitely, I think both of them would be better off by not using the word provider as well. But at the end of the day, it doesn't really matter to me. Again, my subspecialty, super subspecialty is different. So impact on care is the key thing, right? And there are studies that have done that. They have evaluated the care provided by the nurse practitioners as compared to the physicians. And as I said, you can see that the nurse practitioners provide more therapeutic and preventative care as compared to physicians who actually do more diagnostic and biomedical treatments, etc. And this could be just the function of where the patient's severity lies, because sometimes the severity level also distinguishes people coming into the door, which way are they going to go into nurse practitioner or physicians, etc. Or then the physician takes over. And after call, the nurse practitioner says, hey, this is something you need to look at. So I think there's clearly in the market definitely availability for both of them to coexist significantly. But the whole point of lecture over here is not to discuss the nurse practitioner and everything. The whole point is that which specialty you're going to choose. They do provide sort of a different care in terms of actually physicians are concerned, and their main primary focus has been, especially in an ambulatory setting, is towards preventative care, hypertension, diabetes, etc. And I'm going to be very honest, and people are going to hate me about it, they sometimes do a better job than physicians. However, when there's a more complexity, there's more interaction with medications are concerned, there are more situations in which patients require more advanced therapeutic decisions and diagnostic decisions, then physicians do come in and do a better job, in my opinion. Again, these are all opinion. Here's the cost issue, right? At the end of the day, you will learn that as you progress through your senior years into the healthcare and looking at the healthcare industry and looking at even contracts and hospitals and everything, you're going to understand that it's, to be honest with you, it's all about money, unfortunately. And physicians, as far as defining full-time employment is concerned, is 287 hours. But unfortunately, physicians on an average do work more. They work 672 hours, which is about 51 hours per week, not to include the pajama time that we have to put in at home to put in the notes as well. But there's definitely, how do you define full-time, etc., and all that. But at the end of the day, the cost of a physician, if you look at $100 per hour as an average, which again is not really standard, I'm just using a comparison between 155 when things are changing in between states, regulations, and pricing structures, all that. California is different than Nevada, so all of those things do matter, but these are some very high-level generalizations I'm doing. And therefore, you need to understand that. So hire a full-time physician, which is actually now 50 hours of work per week as compared to 40 hours work per week for APP. It's 267, 111, 14, 114K per year. And then there's, of course, difference in the patient load. The physicians generally take care of 18 to 22 patients on an average 20 patients, APP outpatient 14, and patients about 10. So when you equalize it all, generally speaking, when you're looking at the ambulatory cost, generally physicians do provide, the cost is approximately $51 per patient. Advanced practice providers take care of the same thing, about $31 per patient. Again, these are very high-level generalizations. At the end of the day, large systems, hospital systems do save money on advanced practice providers, and therefore there's an acute need for them, and therefore there's more jobs for them, and therefore they are in certain cases replacing physicians as well. But interestingly, if you look at how the amount of time that physicians provide per patient as compared to advanced practice providers, that has been studied too. Generally speaking, time per patient is about 24 minutes in terms of physicians is concerned, but APPs do provide a longer term interaction with the patient, about 34 minutes or so. So clearly they do spend a little bit more time. Again, you can argue why and what and everything, but at the end of the day, these are some things that you should know. So cost and value is clearly definitely important, and these are some calculations that I came at. You can pause and look at all that table, but at the end of the day, the fact of the matter is APPs do cost approximately 2/3 of the cost of physicians as far as outpatient is concerned. And approximately the same holds true as far as inpatient is concerned as well. In inpatient setting, a physician costs approximately $90 per patient, and an advanced practice provider costs around $66 per patient as well. So there is clearly, in terms of cost and value in real world, is much more complicated, right? I mean, it's not just a physician taking care of it or APP taking care of it. And especially in the inpatient setting, there's always either it's a physician only model or a physician plus APP model. And therefore, there is definitely some variations in which these are used. And therefore, they are appropriately, at least in inpatient setting, which again, my overall experience is limited to. They are extremely helpful in extending my arm's length and extending my service personally. And therefore, in ambulatory setting, I suppose that would be different. But overall, again, there's a value in terms of direct dollar amount that they bring to the healthcare system as well. It's okay if you do not believe in whatever I'm saying, but at the end of the fact of the matter is that they do bring financial value to the system. Now, therefore, there's a lot of extension going on, especially in the inpatient setting, in which there's 20 patients per physician, 10 patients per APP, total coverage 40 patients, and you are actually sort of coming up with a little more amount as compared to hiring all physician model, and therefore it could be a little more expensive. Of course, there are unfortunately other factors as well. I mean, who's going to take the night calls, weekend calls, holiday calls, complex patients, admissions versus follow-up, acute and chronic, 12-hour shifts versus 8-hour shifts. These are extremely important inpatient setting issues that are more important than ambulatory setting. But at the end of the day, these are issues that physicians do talk about a lot, that we take more holiday calls or night calls, weekend calls. We end up getting the grunt of the complex patients. We do the admission sort of situation or coordination of care at times, more so in terms of subspecialty care and all that. But there is definitely differences in practice patterns in inpatient setting. But overall, as I said, in my opinion, they are a great help. Should the physicians, then they're asking is like, should the physicians be paid for supervising APPs? And that is the part and parcel that is sold to us as a perk, right? Hey, you're going to have an NP to help you. So again, that's true. Quite frankly, that is true, that if I have an NP, I can take care of this patient. But at the end of the day, then I won't be taking care of 20 patients. I'll be just taking care of 16 patients, right? So there's pros and cons on that approach. But in my opinion, it all boils down to liability, like how much existing liability you're going to take over. Because even though in an inpatient setting, generally they are working under your supervised license. Again, keep that in mind as far as that is concerned. And then other thing is the utilization. The word utilization basically means that how much money is spent per patient by a nurse practitioner versus a physician. And this is, interestingly, they use less acute services, and they overall cost of care provided by the nurse practitioner is lower. That's study. Now, people can argue, and actually I do argue, not people, I'm personally going to argue, because there's overall less complex patients that end up being in their pool of patients as well. But at the end of the day, the fact of the matter is they do not only cost less for their direct reimbursement, they also overall cost less in terms of patient care as well. As far as if there's a primary and subspecialized ambulatory care, there's a systemic review that was done, and then nurse practitioners in alternative provider ambulatory primary care roles have equivalent or better outcomes, and comparatively has cost savings potential. So clearly in primary care potential, as I said, they do cost less overall to the system, and there's a systemic review that actually proves that. And as I said, in my opinion, overall, they do actually do a fantastic job in terms of patient compliance as well. So I think there's definitely, these things are there, published, and you can always question the way the study was done and all that, but at the end of the day, for choosing your specialty, you have to keep that in mind. Provider specialized ambulatory role is not clear. So for example, neurology specific or cardiology specific, there's not enough data to support that they lower the cost and they themselves cost less. But in primary care, that's sort of pretty much set that they do cost less. As far as impact on acute care, in acute care, it is more important improving access than cost of care savings, right? So in inpatient setting, one of the key issues that we are fighting from a healthcare perspective is nothing to do with cost, believe it or not, because it seems like we are bleeding money in patient setting. I think the more important thing is actually access to care itself, and therefore nurse practitioners do improve access for many patients, because without the nurse practitioner, the ICU will be 12 beds or 14 beds. With the nurse practitioner, I can do a 20 bed. So clearly I can definitely improve my services, extending my services in a way that I can actually take care of more patients, therefore making accessibility for those patients who really need it, and therefore they are definitely one of the things you have to concern. Now, cost of education is a big issue, right? At the end of the day, you're going to say, well, you're saying all that stuff, Dr. Clea, that they cost less, and apparently in a primary care setting they actually do overall cost less to the system as a whole. But what about at a personal level? You wouldn't believe, right? The overall average cost of education for physicians was $250K. This was numbers from 2020 and with I think 2018 actually. So overall, the cost of education is going up for both nurse practitioners and PAs. Their average cost of education is actually $44,000 and $63,000. So definitely the cost of education is much less. As a matter of fact, this is not just the cost of education. The cost of education is more so than direct cost, than direct cost is more importantly indirect cost. Then more importantly, the indirect cost is the cost of opportunity. I'm sitting in a medical school for 8 years. There's a cost of opportunity that goes through, right? By the time I actually finish my residency and fellowship and my 401k really starts, I'm actually 31. That could be very different cost of opportunity. So when you really truly cost of opportunity, you're going to calculate, it's about $800,000. For medical school. It's a huge, and again, this was 2 years ago. I think these numbers were 3 years ago. So given the current environment of inflation of 14% or more, this is definitely the cost of opportunity, in my opinion, is now double that, literally double that, because I wouldn't be able to buy my house right now. So clearly things have changed since this data came out. So the cost of education is significantly higher in terms of between nurses and nurse practitioners and physicians. Is the time required for training adequate? Again, this is a talk about not opinions, this is data. So physicians generally in general, put in around 20,000 clinical hours before they are handed over a license. This required typical residency, sometimes fellowship, required clinical hours in preclinical and med schools. These are some big, and purely as a practitioner role, sometimes put in somewhere between as an average 1,000 to 1,500 hours of clinical hours. As far as the physician assistants, 2,000. Clearly, there's a huge difference as far as clinical training hours are concerned between the three subspecialties. Length of education we talked about. Generally, on an average, physicians is about 14 years, nurse practitioners and PAs around 6 years. And then there are people who are questioning that because overall education, clinical training hours is much less. Clearly, there would be a difference, and there is a difference from most places. Again, there are people who I personally argue that in primary basic care, they do have a role. And as I said, as an extender, they do have a role. But again, as an independent provider and as an independent practitioner, do they actually have a total evidence that proves that they should be provider independent? At the end of the day, it doesn't matter. As I said, 26 states have approved their independent practitioner status. So there are states in which they are independently working. Again, I personally think this is important for healthcare because of the lack of physicians and the official burnout. I mean, 1 in 5 physicians are about to leave within the next 2 years. In short, if you look at a humanity perspective, of course, it does make important fact that there should be more practitioners in the system, providers and physicians, everyone. But again, there are pros and cons to that approach. And I personally think that limited supervision by physicians need to be present on an ongoing basis. Chart review once every 50 charts. Something has to be added on top of it. And there are states who do that. Still, even if you're doing full-time independent practice, there is an oversight that you have to follow. Nurse practitioners and physician assistants do fight among themselves as well. Do not put them in the way, and do not sweep PAs into the group, by the way. So therefore, they don't like the word physician extenders as well. Again, one of the things they say that you understandably see less clinical hours even in the nurse practitioner education system. However, as nurses, they have put in a lot more clinical hours, and that's true. Clearly, some of my nurses in the neuro ICU have been so amazing, and they have performed better than newer nurse practitioners that come out of the other ICU. So there's definitely situations in which NPs and nurses are different than PA because of their nursing background as compared to physician assistants. Physician assistants are also extremely important, don't get me wrong, especially for surgical specialties as well. So again, there is a difference. They don't like to be lumped into a one group, FYI. And next time we're going to talk about evolving trends in virtual care and artificial intelligence. Thank you.